السلام عليكم. في مقاعد بس إضافية طبعا جاني تحذير أنه لازم نخلص على الوحدة فرح نستعجل شوي. نبدأ. بسم الله الرحمن الرحيم. البانل ديسكشن حاليا راح تكون عن difficult cases of cochlear implant. راح نحكي عن البانالست راح يكونوا بروف علي محروس، بروف إيمان صادق، بروف خالد بعيو، بروف سالم عمير، and بروف أمل أبو سرويل. دكتور حسين أعتقد أنه ما قدر يجي، بس احنا راح نبتدي إن شاء الله. الحالة الأولى اللي راح نبدأ فيها حالة 5-year-old boy had meningitis followed by bilateral profound hearing loss. هذه الصورة تبعت السي تي سكان بتاعته. إذا أنتم شايفين السي تي سكان there is evidence of calcification. إذا أنتم شايفين بالleft والright side. With this case, دكتور خالد. في عندنا مايكروفون. Are you happy with the CT scan? Enough? Is the CT scan is enough for this case if we are going to do cochlear implant?
شنو السؤال يا دكتور فراس؟
سؤال هذا السي تي سكان
تمام.
هذا كافي بالنسبة لك عشان to proceed with cochlear implantation?
No, it's not enough. In patient has hearing loss because of meningitis, we should do MRI for the child.
هاي الام ار اي سكان للبيشنت.
Actually, in the MRI, we will see whether there is patent cochlear duct or not. If the cochlear duct is not patent, so in this case we cannot do cochlear implant. But if the cochlear duct is patent, we will do cochlear implant. But we have to do the operation as early as possible. To prevent fibrosis and sclerosis. But before that, Dr. Firaz, we have to check the hearing of the patient. But I think it's
that's profound.
You mentioned that the hearing is profound.
Yeah, Dr. Amal, when راح تعملي cochlear implant if you are going to do this case?
I think this is difficult from CT scan finding because of severe ossification. But I think the left, if it is considered this, the right.
This is the right. There is nothing here.
Left.
And this is the left.
I think that the left one is
okay.
More acceptable.
So. What are you going to tell the patient before or the family before the surgery? لا لك سؤال دكتور عمل.
We have to discuss seriously here with the families that is the case is not straightforward. It is something we might face difficulty even intraoperative to insert electrodes especially. We might operate in one ear if it is not successful and insert electrode, try to insert the tester before we don't bed in the one ear. If it is not successful, we have to think to go to the other ear as to discussing to the patient family from the beginning.
So there is
family request consent about.
There is a chance that you are not going to do cochlear implant
yeah, we have to discuss carefully the failure rate that is might be high in insertion.
Dr. Iman, what's the outcome after doing cochlear implantation for post-meningitic calcification?
Well, it will depend upon the number of electrodes which could be inserted operatively, the number of viable ganglion, and sometimes after cochlear implantation in meningitic patient, we have some sort of central auditory processing disorder because meningitis may affect the brainstem, may affect other structures in the brain, not just the cochlea. But sometimes there is the temporal processing is affected in such patients. We have a research upon this, and the temporal processing is affected in almost all cases with meningitis, which makes the speech and language understanding after cochlear implantation less than the normal expected from any other sensory neurohearing loss because of the central affection.
Do you have any problems later on, after 1 year or 3 years?
I have actually one patient, after some time there is further ossification and some electrodes I'm not able to stimulate them, and one of them it's just 1 or 2 electrodes which are after 20 years of implantation, just 1 or 2 electrodes, and it was a good surgeon who did the operation, and so we turned back to the hearing aid in this ear.
Okay.
It gives a better sensation of sound than the cochlear implant, but sometimes it happens.
Dr. Salim.
According to the CT scan, there is no place to put any electrodes.
Okay.
Of course, brainstem implant is a better choice. Before the era of the brainstem implant, I hear about implanting the semicircular canals يا دكتور علي.
Okay.
واحدة منهم الثانية مش ossified the semicircular canal.
Left canal. Okay.
أيوه.
Do you have any experience with brainstem implant?
Of what?
Brainstem implant.
No, of course. No.
Dr. Ali.
I think for this patient, Dr. Fras, I would do the MRI scan immediately before seeing the family because it may change by day. So I would not rely on MRI scan that is done 2 weeks ago because it's an active process. That's number one. Number two, I would then really do MRI brain as well because this may give me an idea about the central affection as well. I think, if it's accompanied with encephalitis or something like this, this may be a prognostic factor here. Now, in my experience, cochlear implantation is far superior to brainstem implant. So I would try left cochlear implantation here first. With one proviso is that the family should be on the understanding that this is like a trial. We're gonna try it. If it succeeds, it's God's help. If it doesn't, then we should not be blamed on the outcome of this patient at all.
Okay, just a comment. What do you think about a drill-out technique for cochlear implantation when calcified cochlea? Any outcome?
In this patient, I feel that this, because I could see on the MRI scan that there is a fluid, and actually there's a scala tympani and a scala vestibular quite clear. There's a blackish line in between the two, which is really good because that means I can actually find a slot to insert. But then it really depends on, at the time of surgery, what I would do, Dr. Fras, is that I really make a drill, and if there is a lumen, then I would try to insert my electrode, and I would usually ask the companies to give me like a dummy electrode in this. And I use the perforator of a staples surgery. Sometimes I use the perforator to create a wall and a hole, and so I really try everything with these. So
actually, what I do is to try with a cannula, a hard cannula to push, because sometimes there is some fibrous tissue inside and you can push it around. But it's acceptable now that trying with cochlear implant is much better than brainstem implant. I had some experience. I had some experience when I was in Manchester with the brainstem implant. It's a very stressful situation. Everybody is waiting. We are afraid that the patient will have some kind of breathing problem, some kind of irritation. So the patient will stay in the ICU after switch on. So it is a major life event for the patient and for the surgeon as well. So if you can do cochlear implant, just go for it. If you can't, try to drill, and this is the message. So next case. We have 14-year-old girl with bilateral hearing loss, the left severe hearing loss, and using a hearing aid, but the speech discrimination was 30%. The right had profound hearing loss. She had cochlear implant in the right when she was 4 years old. She stopped using the hearing aid 6 months after the implantation, and she is seeking bilateral cochlear implant 10 years after the first surgery. So, what do you think, Dr. Khalid? Yeah, so she had the cochlear implant. She did very well with the cochlear implant. She stopped using the hearing aid because the cochlear implant was superior to the hearing aid. She stopped using the hearing aid and then started, after 10 years, the family was asking about having another second cochlear implant. So.
I think a trial of cochlear implant at the age of 10 years, the result could be not good. If the surgery is done at the same time, even if the speech discrimination is not good, the child will have benefit from the cochlear implant. But cochlear implant at 10 years, I'm not sure about the result that will be good or not good. If I decided to do that and the family insists to do the operation, I will explain to them that, and before that I will take the opinion of the audiologist to know whether this operation will be beneficial for the patient or not.
So what do you think, Dr. Iman, about...
For the left ear, which was the better ear, she used hearing aid for how long?
After having the implantation, she suddenly stopped using that because she was with the cochlear implantation.
I mean, she developed speech, some speech and language with the left, with the hearing aid.
She developed.
What is the first message is when you have a unilateral hearing, unilateral cochlear implant, and you have some remnants of hearing in the other ear, don't stop the use of hearing aid. This makes it possible to do the cochlear implant after some time. Yeah. But if you stop using the hearing aid, it will be very questionable, the result from the other ear. She will hear very good, as regards as hearing. The threshold will be near normal. But the discrimination, this is the problem. Okay. Because we don't know if she could hear well with the hearing aid before stopping using it, for how long she used the hearing aid. If, for example, if she used the hearing aid for 6 years and then she stops, there is a chance to benefit from the cochlear implant. But if she used it for just a few months or 1 year and with no benefit, and she stopped using the hearing aid for 7 or 8 years, there is no place. That we have to have a good history of the hearing aid history, and what type of rehabilitation. And if she didn't stop the use of hearing aid and there is stimulation, there will be a chance. But in such a case, it's very guarded.
Okay, Dr. Amal, do you usually do, if you are going to do bilateral cochlear implantation, do you do the bilateral implantation at the same time? Or sequential?
Yeah, first I want to ask in the previous question. Before we were talking about this, in that we are depending on the period of hearing aid deprivation, I think, to think about implantation of other ear when she is stopped using hearing aid.
She was happy with the cochlear implant, that's why she relied on the cochlear implant and stopped using
if it is a long time, we might face a speech discrimination problem. If it is this is very nice to implant the other ear. And regarding this bilateral in one stage, this is, we might preferable a sequential first, implant the first and see.
If you are going to tell the patient, the family came and they are thinking about bilateral cochlear implantation. So do you advise them to go for bilateral on the same time or sequential? And if sequential, what's the limit between the first and second surgery?
As not preferable for me. We give a period for rehabilitation and using a hearing aid on the other ear to make ready for next ear implantation later on. But
any other opinion, Dr. Sam?
سوري يا دكتور فراس، هو انت سؤالك عن البايلاترال دلوقتي منفصل عن السؤال الاولاني بتاعنا.
احنا
صح؟
السؤال الاولاني she might not improve with the second cochlear implant because she stopped using the hearing aid after for a long time. So we have to advise them that.
Well, again, this is, I know that this may be a disagreement here, but I would actually try to find out whether there is any functional hearing on the side where it's been deprived for a long time, asking Dr. Iman to see, don't you have like this P300, P100, this is cortical evoked something. There is something called functional MRI, there's something called tractology. I know that this is still no evidence to support to rely on it very much. But I think when they come to the baseline of it, Dr. Firas, I would say to the family, this has been deprived for a long time. We're not actually sure whether this is gonna help your child to develop better hearing as such, but it may help localizing the source of sound as a sound detection. And if the family agrees, then that's fine. If they don't agree, then it's up to them. That's what I do.
For the cortical, it's not going to help because I know that she will hear with the cochlear implant. There is no problem in hearing. I know that there was stimulation previously for this side, for the side which was not implanted, but she was using a hearing aid. It's stimulated. I know the P1, it will be there. It's just detection. Detection does not mean discrimination. Detection is just detection of the presence or absence of sound, but not discrimination. فإن such a case حتى لما بيبقى كده وبيبقى في فرق أكتر من سنة أو سنتين دايما بيبقى في preference للفيرست one، عشان كده إحنا بنفضل يبقوا مع بعض، أو لو كان يبقى very short time in between. حتى اللي بيبقوا مستعملين one if they stop the use of hearing aid in the other ear وبيبقى بعد سنة أو سنتين بيفضلوا برضو يعني أكتر من سنتين ما بيبقوش عندهم preference للودن دي. They detect the sound but they do not discriminate. فلازم العيان يبقى عارف كويس قوي هو هيستفيد ايه. هو هيستفيد صوت، فساعتها نعمل aided response. لو الايدد ريسبونس بيبقى لان هي الصوت الكوكلير امبلانت مش هيبقى بالنسبه لها حاجه ظريفه، هتبقى نفس احساسها بالهيرنج ايد، هتبقى حاسه بالصوت لكن ما فيش ديسكريميشن منه. فلو الهيرنج ايد بتديني جود ايدد ريسبونس، لو هي سيفير واقدر ادي جود ايدد ريسبونس، هيديني الباينورال ده. فهي تتحسب يعني.
So we agree that bilateral is better than unilateral. لكن الكل بيفضل انه يعمل sequential ولا بيحب يعمل on the same time.
I think even this is tallies with nice guidelines. Is to do bilateral simultaneous cochlear implantations as long as the patient is the mainstream patients, lower prelingual young child, then bilateral simultaneous is the way forward. No cochlear anomalies, no further disabilities, that kind of thing. But there are situations where you have to do it sequential because you're not sure about the outcome, for example. So you implant to one side and then see how it goes, and then you can implant the second side if there is a benefit out of it.
How long you wait?
Within, I prefer it to be within actually 1 year from the first implant. However, the evidence doesn't really answer this question. I don't think
there are some studies recently that the non-users after having sequential cochlear implant after 2 years, the non-user is more than the average. So they will end with non-user on the second implantation. So it's better to do it as soon as possible after cochlear implantation. The problem is financial. يعني الأهل بيكونوا جمعوا ثمن الكوكلير امبلانت فيرست، السكند بموتوا تيجمعوها إذا قدروا يجمعوها، فعشان هيك احنا بنعمل. دكتور سالم.
والله أظن في دولنا العربية مش ضامن التعقيم، مش ضامن الخدمات ما بعد الجراحة، فأظن يكون في فترة بيناتهم يعني.
إذا قدروا الأهل يعني نمشي on the same time.
صح، في اختلاف بين الدول بصراحة يعني. بس أنا في نقطة إن حكاية التعقيم والعناية ما بعد العملية والأشياء هذه نخاف إن تعمل لهم اثنين مع بعض، إن يحصل فيهم انفكشن هم اثنين مع بعض.
الحقيقه احنا ما عندناش مشاكل خالص في البوست اوبراتيف، والدوله عندنا بتدي 1 cochlear implant that if the parents can afford for the second one it is the best to do in the same session bilateral CI if it's indicated.
احنا كل الدول العربية أعتقد مع يعني كانوا providing single implantation for the pediatric. This is المعظم، لكن bilateral ما حد يعني التأمين ما بدفع على bilateral. ف يعني في دول الخليج ممكن يدفعوا bilateral cochlear implantation. إذا كان في حد يدفع يعني بنعمل bilateral. احنا عشان التايم limitation، وانا عارف انا شايف التهديدات اللي بتيجي قبل كل شوي. Case 3. 3-year-old boy presented with bilateral profound hearing loss. This is the CT scan. Where are you going to implant? Dr. Salim.
This is a deformed cochlea, of course, and I think can be implanted. Which? Ah. I think the right side.
The right side is much better than
Yes. The right side.
Do you have any experience with congenital deformity of the cochlear implantation, Dr. Khalid?
Yes.
Actually, I have done one patient only, and this patient has acidity in the blood. I don't know this name, and I implanted this patient at the age of 3 years, and the patient actually has good result. Furthermore, actually, maybe 6 years ago, we implanted maybe 2 or 3 cases while Dr. Firas coming to us as a visitor and teaching us cochlear implant.
دكتور أمل في عندك أي
Yeah, we are familiar with the minor malformation. We implant a minor like Mandini. Here we are preferring the right. The left, I think it is severe malformation because it includes the cochlea and vestibule. We are afraid here from difficulty of insertion in the left side and difficulty of gusher. So I am preferring the right, and we are dealing usually with a minor inner ear deformity. Severe is still we are have no experience to implant severe malformation.
احنا الحقيقه عندنا في مصر بنشتغل الكونجنتال مالفورميشن، يعني حتى انا عندي اكسبيرينس مع common cavity مع IP1 IP2. طبعا the less the deformity the better the response. انه يقدر يسمع. هي بيبقى فيها difficulty شويه في البروجرامينج، يعني you have it's not the conventional way of programming. بالنسبه لكل ما الديفورميتي تبقى اكتر بتبقى مختلف الطريقه بتاعت البروجرامينج. اهم حاجه طبعا الكونسلنج للبيشنت والاكسبكتيشنز. بس sometimes even the mere detection of sound makes a difference for the patient. فطبعا النتائج ما بتكونش كويسه قوي، وساعات sometimes we don't have result, sometimes there is sound detection but they use sign language. It depends on, it affects the outcome, but it's not an absolute contraindication. So long the parents know, or the child parents know the limitation of cochlear implant, in such case we do the cochlear implant with the visual cues, with the intelligence of the child, with support of the family, we might have accepted results.
Dr. Ali, do you have any facial stimulation with congenital anomalies, implanting congenital anomalies?
Yes, I do. Actually, the facial stimulation is much more with otosclerosis. I think that we see quite frequent. For this patient, this is IP1 on the left side, And this looks to me, I cannot judge it from one cut, obviously, but it looks like IP2 on the right side. So IP2, the outcome is much better than IP1. In fact, actually, if you give me, I prefer to operate on IP2 and IP3. IP1 is easier for the surgeon, but it's actually the outcome of it is much worse than the IP3 and IP2. So I would be very guarded if I were to operate on this left side, Dr. Frost. But the stimulation is more with a common cavity compared to the rest, but obviously otosclerosis, facial nerve stimulation.
How to deal with facial stimulation?
I actually phoned Dr. Iman Sadeh to switch off the offending electrode.
We have experience with the patient operated actually by Dr. Firas when he came to Libya, and this girl is syndromatic. After the operation, this child, after hearing any sound, she started blinking the eye and facial stimulation. Could be common cavity. I don't remember. So the thing which done for this patient,
Partition.
yes, the thing which done just pulling the electrode a little bit and the patient.
Just a question to Dr. Iman. The biphasic stimulation and triphasic
Yes,
stimulation.
I was just want to add, for MEDAL, they have the triphasic, which helps a lot in case of facial stimulation. We can stimulate the electrodes who gives facial stimulation with biphasic, with a triphasic pulse. And actually, I have some experience with adults, and they do not notice a big difference in sound quality when I shift from the biphasic to the triphasic, which is good. But for the others, I try first to increase the pulse width to stimulate this electrode with less current. Sometimes the facial stimulation is off. If I have no other way, I turn off these electrodes, and the frequencies will be shifted to the other electrodes. 1, 2, 3 electrodes to be turned off, it's not a big deal.
So is there any preference to the electrode you are going to use for such congenital anomalies?
Which are you talking about? Facial nerve stimulation?
No, I'm talking about the insertion for the cochlear implant and to prevent facial nerve stimulation as well.
Yeah, if I have a common cavity, I prefer to use the full band electrode because I don't know which nerve is where. So I use like a full band electrode. I abstain from using any perimodular electrodes, so I use a straight kind of lateral wall full band electrode in a common cavity, and in most of malformations actually, except in otosclerosis. That's not a malformation, but in otosclerosis, I prefer to use the perimodular electrodes to avoid facial nerve stimulation.
And if the electrode has got a stylet, do you use off-stylet technique? Insertion without stylet, or do you keep the stylet while you are inserting?
If I am suspecting a resistance, I actually keep the stylet to the end and then withdraw the stylet. But if I'm not expecting, then I would do it as usual.
Our fourth case. We have got 14-year-old young lady, profoundly deaf, was implanted at the age of 3. She was doing great with cochlear implant, but recently she started to have pain around the device with loud noises and poor discrimination. Dr. Salim, what do you think?
Immediately, I will refer her to audiologists. Audiologist.
What are you thinking about?
I think she have a retrocochlear lesion or presbycusis that affected the quality of the sound.
She was doing great with cochlear implantation. She didn't have any problem. She didn't have any trauma. And suddenly she started to have... She was doing great. And then...
Pain around the device. She developed pain around the device.
Developed?
Pain around the device.
So in another way, what's the signs or symptoms of failing device?
There is no swelling.
No swelling.
or tenderness?
No tenderness, but she stopped using the device because of the pain. When she used the device, she started to have pain, some kind of electrical stimulation.
I will look for the skin lesion. Maybe there's a pressure necrosis starting.
Nothing. She had it. She had it 11 years ago. The cochlear implantation. It was great. So until 2 weeks ago, and she started to have problems.
I should do CT scan to detect any
So-
bony lesion.
Dr. Aman? The X-ray was done, no problems, everything. The electrode inside, coiled. The implant was not cracked, nothing. So what do you think?
We have to see the opinion of our audiologist
Okay, so
regarding the function of or inserting electrode.
so we will send the patient to Dr. Iman. What do you think, Dr. Iman?
First, I will change the whole external processors with another processor to see if the problem is the external part or the internal part to start with. If the problem remains, I'm going to start to think of perhaps there is some sort of trauma, mild trauma, but which was direct on the internal part, or I may think of soft failure of the device. I'm going to do the impedance to be sure that there is no short circuit, there is
The
no open
impedance was
circuits.
okay.
Was okay.
No problems at all with the electrodes.
And the ECAP,
The ECAB, few of the electrodes didn't give any responses.
and previously
But
it was giving
it was
response.
okay.
In such case, I will think of internal device failure.
Okay, so, okay. Dr. Khalid, thank you.
Actually, in this patient, I have two decisions. Either I keep the implant or I take it out. And my decision will be depending on, first, as Dr. Salim said, I will, this actually multidisciplinary team should work. The patient should be fully investigated by the audiologist and also need to be seen by a rehabilitation team. The one which should be done for this patient, integrity test is important. If everything is all right, integrity test is okay, and the rehabilitation team has no anything wrong in this device, so the next thing I will take this device and replace it by another one, and I have to follow the patient, reassess the patient after the rehabilitation to see the result.
We have got a problem here. If we are going to remove the device and re-implant, we have to have a strong evidence that the device has failed. And the company will resist such cases to admit that the device has failed. So what to do? Dr. Ali, do you have anything?
I have encountered several patients of these, and I have like a flow chart in my head, I think like Dr. Iman said. First of all, I make sure whether this pain is when the external part is worn or not. And if the external part is worn, then in my head actually, this is 99.9% is an infection till prove otherwise. So I start them, and this rightly or wrongly, I start them on vancomycin as antibiotics. Simultaneously CT scan on I would just before this to make sure that the electrode array is in situ and no problems, being anatomically no problem, and again the audiologist's opinion at the same time. Then take it from there. Whether the pain is going to improve or not, this is another issue, and probably the company should be involved as well to make sure that the device is okay from their perspective, and then make a decision there and then.
Yeah, Dr. Ima.
I have one patient who give some sort of this يعني حاجة very similar, وهو الحقيقة لقيته he developed migraine after being implanted. وساعتها sometimes, not all the time, with the loud sound, when he has this attack of migraine, he cannot tolerate the device. He feels severe pain and cannot even is not able to hear. But of course, we have to differentiate and to be sure that without the device, he has, in such case, he turned off the device and go to a dark place, and he is okay. When I give him treatment for migraine, he was much better.
Okay.
But of course, we have to revise first the map. Sometimes there is some difference, but the problem is in the ECAP, which was present and then absent.
So what about the integrity test?
Yes, we have to do to see if there is internal failure or not, and we have to tell the company, and we do the integrity test, and if there is a problem, they have to.
Do all companies have got integrity test for their devices?
They do integrity testing before you implant the device.
No, they can't do integrity test after implantation.
Well, the companies would say we do integrity test after you explant the
No,
device.
it is the test for the device, for the internal aspect. But
Yeah.
they have got a device that they will usually bring it from outside, and they will come and do. They connect it, and they will see the circuits of the device. I don't know
But
exactly what kind of the test.
audiologist, can you not do this? Yeah. Okay. All right. Okay.
الكومباني
Yeah. Okay.
هم بيطلبوا هذا الشيء عشان يعوضوا بدل الجهاز ولا لا.
Evidence.
يعني طبعا بيغلبوا كثير، لكن بالاخير اذا if you push them they will accept.
It happened, and sometimes the integrity test point to an internal figure, and we do the explantation.
Yeah.
It happened.
And they provide the
Yes, the internal part. Yes.
Okay, so we covered that. So this is a new case. We have got 2-year-old girl, had a history of RTA with head injury. She was admitted to the ICU for 1 week. Due confusion and reduced level consciousness, she had bilateral skull-base fracture with a profound sensorineural hearing loss. The plan was to have cochlear implant. What are the precautions for this girl? History of trauma. She had bilateral profound sensorineural hearing loss. She's going to have. They came after 2 months after the accident, and they were asking about cochlear implantation. So what do you think? What, Dr. Salim?
We are afraid we may have fibrosis here due to the fracture.
Okay.
Also, we have to be sure that she is indicated for cochlear implant audiologically, maybe a trial of hearing aid.
Okay. She has got profound hearing loss. She didn't improve with hearing aids.
Okay. Also, during the surgery,
she is postlingual anyway. She was doing well before the accident, but after the accident, she had this problem.
Also, we have to care about CSF leak during the operation.
Okay. So we are thinking about a fracture that involved with the cochlea. So longitudinal fracture. But Dr. Khalid, what kind of the trauma after the hearing loss after head injury? It is because either complete cut of the nerve, or concussion inside, or fracture involving the cochlea. So if this is the concussion, kind of we can do cochlear implantation. If it's a complete cut of the nerve, so we might need to do MRI scan to see the nerve, if it's okay or not. It was okay, there's no problem. But we were afraid that there is something inside, calcification or fibrosis. She didn't have any calcification, so there was, I don't have the MRI, but the MRI was okay. So we did the cochlear implantation.
And if the recent RTA, I think it's better to be done early.
It's better. لكن خلينا نشوف في صورة sorry. This is the intraoperative measurement of the patient. She had, the impedance was perfect. The NRT, she started to have the 7th electrode, the initial 7th electrode. It was a full insertion, so we reached the marks of the electrode. She had only this kind of electrode give NRT. The inner part didn't. This is the cochlear from cochlear company. So the 22 is the most proximal, or the inner part of the electrode, and electrode 1 is the round window electrode. So this is the case. Actually, it was done, I think, in Musrata, I think. Anyway, but okay. So what do you think from this kind of testing? Was that enough for you? Usually, if we don't have enough, if you have got partial insertion, we will have the inner and we don't have the outer. So here, the other way around. So,
as I said in my talk about the outcome of CI, it's not really by pure tone audiometry. So, but this is reversed. I'm a bit surprised. Sorry, I cannot see it.
it is reversed. Yeah, the inner part didn't give any signal. The outer gave the signal.
All right. Okay.
So,
Yeah.
so, but anyway, the next question was, during the surgery, if you have got this result, what do you do? What's the advice from the audiologist?
This NRT is during the surgery or after the surgery?
No, this is intraoperative.
Intraoperatively, if the surgeon is quite sure that he put the electrode in the right place and he did his job very well, and if there is a possibility of imaging in the same session, this will be okay. If everything is okay and just we have NRT in the basal part, yes. So we don't have anything else to do, and we will try to, sometimes the ECAP is present post-operatively and it's not present intraoperatively. Sometimes it occurs.
If this surgery is going quite smooth, the
It
insertion
was quite smooth.
was full,
without any
and the
resistance.
surgeon is confident about the insertion, we have to close and test post-operative.
But actually,
Because
okay.
it be simply by CR.
This is the ideal. We didn't do it. And after that, this is the imaging. So the electrode went through, this is because of the fracture actually. So it went through basal term, and then it reached by chance, go in internal uterine canal and then intracranial.
But how come the preoperative imaging did not detect the fracture?
Didn't, so it says at the bottom. Anyway, so.
Also, we may have air bubbles and some electrodes does
it
not
was,
be detected.
No, the CT scan was done about 6 weeks after the surgery. Because
No, in another case, I mean.
yeah, but yeah, usually we have to do post-operative radiological testing. We did a study, and this case was very difficult and very different than the others. If you have got complete intraoperative measurement, ECAP was done and impedance was okay, there is no need to do X-ray immediately after the surgery to check for the position. But if you have got any problem, congenital anomalies, difficult insertion, and satisfactory intraoperative ECAP, you have to do immediate X-ray just to make sure that you are doing well.
Can I just add something?
Yeah.
Actually, when we started learning in cochlear implantation, we used to be, everyone was teaching us that in a 20% of cases, if you don't get impedance and ART or ECAP, then that's fine as long as you have inserted the electrode inside the cochlea. Now, actually, with the recent devices here, myself, if the impedance and ART is not really going to my liking, I would always scan them.
But the other way around, if you are having everything is fine, do you need the X-ray, for example?
No.
What's the chances of having complete NRT or ART or with full impedance?
No.
What's the chances of having the electrode outside?
No, I would not X-ray them unless there is something that is
Yeah.
not typical.
Okay,
Yeah.
so this
Yeah.
is acceptable. Mike, طيب, okay. For the final remarks, for the future cochlear implantation, what are the negative points of current cochlear implant devices? How can we improve the devices in the future? Dr. Khalid, what do you think?
Actually, the main complaint of most patients regarding cochlear implant, they want the cochlear implant to be completely inside the ear.
Fully implantable device.
Fully
okay.
implant. So this is actually the good point for the patient if the cochlear implant is internal.
I agree with Dr. Khalid, and we have to start with very slim PID and device here for better outcome, and I think I agree with
Yeah, there is actually some evidence about drug-eluted electrodes. There is drug-eluted electrodes like a stent, drug-eluted stent. So they have got some growth factor and some steroid with the electrode, so to reduce the chances of fibrosis and to stimulate the nerve ending. So this is one of the completely implantable devices still under research because of the problem with the microphone. The microphone, the inside microphone will collect everything, for even the internal sound, which is the limitation. What do you think, Dr. Iman? From the audiological point of view?
هو الحقيقه احنا كان التكنولوجي في الهيرنج ايدز was much higher in processing than the cochlear implant before, but with the combined work of three main دلوقتي companies عندهم يعني بيشتغلوا مع companies of hearing aid، فالحقيقه الاكسترنال بروسيسور بقى احسن بكتير as regards processing, as regards directionality, connectivity, all these things. هو اللي فاضل الحقيقه هو انها تبقى اصغر، يعني مش هنقول انها completely hidden, but it should be especially the off the ear. Off the ear it's a big device وهي المفروض انها معموله علشان خاطر ما تبانش، ففي الرجاله الحقيقه بتبقى باينه قوي، في الستات بتبقى معموله. فاي ثينك هو اهم حاجه يشتغل عليها هو الباور سبلاي، هو ده اللي محتاجين. هو مشكلتنا السبيتش بروسيسور is very small. The problem is in the power supply. هي to improve the power supply تديني باور اكتر لمده اكتر، فما نقدرش ما نحتاجش للبيج سايز اوف ذس.
طيب دكتور سالم، سؤال عن عدد الالكترودات مثلا.
انا متاكد ان الالكترودات هيزيد عددها خلال السنوات القادمه. ايضا حجم الانترنال ديفايس
سمولر
اكيد هيكون ورقي، عباره عن small piece of paper. You need no drilling here. لكن اظن حجم الالكترود هيكون
عدد
يعني
الالكترودات،
لكن عدد الالكترود هيكون اكثر.
Do you think عدد الالكترودات بيزيد الاوتكم؟
اظن نعم.
لانه
عدد الالكترود اكثر
يعني
من 20
يعني
أو
مثلا
22.
في عندنا في 12 في 16 في 22. طيب لو زدنا شو دكتور علي what do you think؟
discrimination.
You know, the thing is, if we look back in history, it was a single channel electrode. And I know of children who've been implanted with a single channel. Actually, they're doing reasonably okay. So I don't think if you exceed than 22 electrodes, that would make a significant...
Actually, some companies did 32 electrodes.
Yeah,
and they did 42 electrodes, and unfortunately the outcome was not good. So
I think this is for marketing purpose, to make themselves stand out, but I don't think scientifically it makes a difference.
Actually, what happened is there are two concepts: the number of the electrodes and the spacing between the electrodes. So the concept, you need good space because the adjacent electrode will act like one electrode.
Yes, that's right.
So if we will change the stimulation from electrical to something else, we might increasing the number of electrodes without the interference between adjacent electrodes.
And the evidence is quite clear. We have implanted kids with 12 electrodes and implanted kids with 22 electrodes, and there's no significant difference. So, 24.
Okay, robotic surgery. And I think by this we will conclude. This is 1 o'clock. أنا خايف بطلعك وفي حدا بتطلع من هناك واحد بتطلع من هناك. أيوة. لا عملناها خلينا and thank you. تسحب الالكترود وتعمل reinsertion يعني preferably with something يعني imaging. هذا المسج انه اخذت جزء يعني